Alrighty. Okay. So yep, so I'm a gastroenterologist, board certified. I'm from the Department of GI and Hepatology over at Keck School of Medicine. I'm so honored to be able to speak to you all. Alexandra has been kind of walking me through the program, and I think it's such a great program, to be honest. I think that transfusion-free services is not only economically beneficial, but also very respectful to certain faith practices. So I've been very excited to learn more about it, and I consider myself an ally to the program. So if there's anything I can do in the care of any of you, please come by my office. I'd love to see you and try to help out in any way that I can. Today, I really just wanted to give a broad topic overview of GI health and disease. I feel that the best way to maintain health is by preventative care, of course, and I feel like a lot of people don't really get access to the medical profession, doctors, nurses, and sometimes that kind of leaves you in question, and you don't know, when do I need to go see a doctor? Is this normal? What am I feeling? So I just kind of wanted to run through some brief topics, basic stuff that at least at home you're equipped with this knowledge and can present to your primary care doctor, can present to a gastroenterologist if needed, and hopefully take care of your gut health in this way. Let me go ahead and advance here. Okay. So here are my objectives. I really just wanted to take you through some basic topics. As I mentioned, screening for GI cancer is a very big deal, similar to other professions. Screening is always, something that we should know about so that we can get in touch with a doctor at the right time. I'm going to go through some things that are considered normal, abnormal. I also wanted to review my specialization that I will be bringing to Verdugo Hills Hospital, and that's pelvic floor disease, both in men and women. We're going to talk about briefly kind of a workup for incontinence, constipation, and anal rectal pathology that can be evaluated using manometry, which is a specialized tool that I'm able to provide to my patients. And then I just wanted to kind of go through, when should I go and see a doctor? What signs, symptoms am I feeling that would benefit from being evaluated by my primary care physician or a gastroenterologist if you have access to one? So first, very briefly, cancer prevention and detection. You really can get cancer anywhere in your body and anywhere in your GI tract. Some places happen more common than others in certain countries or areas of the world. For example, esophageal, gastric, liver cancers are more prevalent in Asia, and that's because of certain infections such as Helicobacter pylori or H. pylori, or even hepatitis B, and how prevalent it is in these countries. And then in the European and North American regions, colorectal cancers and pancreatic cancers are actually considered the most common. Colorectal we'll talk about. We've done tons of research on this. We know a lot of preventative guidelines, a lot of screening guidelines. Pancreatic cancers, to be perfectly honest, are still very poorly understood, where they come from, what risk factors are there. Generally speaking, we just know that smoking really increases your risk factor of getting pancreatic cancer, but we don't really know, should we be screening for this? The studies that we've done haven't really shown us too much, but we're focusing on it because it is a very prevalent cancer, and it's something that we don't really have a good handle on just yet. But today I'm going to be talking more about colorectal. And then, these cancers can present in a variety of different ways, which is why I'll kind of go through some symptoms that you should look out for that might trigger you to go and be seen by a doctor. And then I'll go over some screening guidelines because you should be screened if possible. So starting with colon cancer screening, like I said, we know so much about this. I think every practicing gastroenterologist is involved in some project related to screening at some point in their training career. Previously, actually, it's been recommended to get screening done starting at the age of 50 years old if you are considered average risk, meaning that you don't have anybody in your family with a history of colon cancer. You don't have any known genetic mutation that could increase your risk of colon cancer. You're kind of, just want to get screened. You're a healthy individual otherwise, and you want to make sure that you don't have anything that could lead to cancer or have cancer at the age of 50. But recently that recommendation has been updated, and I'll get to that in just a minute. Poorly understood, I think, amongst the general population and not very well advertised. Really only if you talk to your physician will you get this information, but you actually should be screened way younger if you have a first-degree relative who's had colon cancer diagnosed younger than the age of 50, even 60 sometimes if you consider it. You should get screened at 40, which is very young, actually. And that's kind of when you start to see a doctor regularly. By the time I see people who have family members who've been diagnosed with cancer at a young age, they're usually closer to 50 because it's not very well understood that, in fact, that increases your risk of having colon cancer, and you should be seen at 40 for it. In fact, patients who even had family members that have had advanced adenomas or precancerous polyps in their gut, they also should be screened at 40 years old. And then even younger, actually, if you've had a first-degree relative that's been diagnosed even younger than 50, maybe at 45, you're supposed to get screened 10 years younger than the youngest first-degree relative that's been diagnosed. Also very not well understood. So if someone was diagnosed at 45, then their family members should get screened at 35, which is very young. And then if you do have a genetic mutation, usually you would know about it at a younger age, because whenever your first-degree relative has been diagnosed with some type of cancer that increases a risk for a genetic mutation, they would get tested and then they would be told to tell their family members. So usually younger people know when they're supposed to get screened, but in case you don't, and you do have family members that haven't been tested once they've been diagnosed with cancer, you're supposed to get screened in your 20s if you do have a genetic mutation such as Lynch syndrome or another type of familial polyposis syndrome. The most recent update and recommendation actually came out in 2020. It was recommended by the American Cancer Society in 2018 that all average risk individuals should actually start getting screened at 45 years old. They did a ton of research about this and basically found that the rates of cancer in the 45 to 49 age group has actually been going up, while the rates of colon cancer in the 50, 60, 70-year-old age groups have actually been downtrending. So that was pretty significant. And we feel that maybe we've been missing cancers in that younger age group, in the 40 to 60 age group, because we're not screening them early enough. So the American Cancer Society stimulated this discussion, and soon enough, the U.S. Preventative Services Task Force, or USPSTF, and the GI societies, in fact, have all stood behind this guideline, because the data really does confirm that you could be picking up advanced adenomas between this 45 to 49 age group, which increases your risk of colon cancer development pretty young. So now the new recommendation, and hopefully insurance companies will be backing this up as well soon, is to start your screening at 45 if you're otherwise average risk. Younger screening ages, though, are still the same recommendation, and it's good for you to know about that. So how do I get screened for colon cancer? There is a ton of different ways. The original and very well-studied way is to test your stool for fecal occult blood. And that means microscopic blood in your stool that you might not necessarily be seeing, but it's being shed by these polyps that can potentially turn into cancer. And you can pick that up microscopically on your stool studies. There are other studies that are done similarly, but they have to be done every year to be accurate. So it's not like you get it done at 50 and then you come back at 60. It's that you get it at 50, 51, 52, et cetera. And once it's positive, then you have to move on to a colonoscopy, which is what I'm sure you guys have heard about, where you take a camera at the end of a long hose and you go all the way up inside your large intestine and make sure that there's nothing sitting in there that could potentially be cancer or turn into cancer. But the other ways that you can test, you have the FOBT stool test, you have a fecal immunohistochemical test, which is actually testing for particles on a polyp. And then you have something called Cologuard, which is actually a DNA test looking for polyp DNA material. And if that's negative, you can actually maybe even go 2 years before you get tested again. But they actually don't recommend that you wait 3 years to get tested again, because then the accuracy goes down in terms of whether or not you're going to pick up on a polyp or a precancerous lesion. Then, if you wanted to take a camera and take a look inside, we have 2 different types of studies. The first is a flexible sigmoidoscopy, where they go in really just in the bottom part of your colon, around your rectum and the lower part of your intestine. And we're just looking for polyps because that's a very common place to get polyps. But to be perfectly honest, it's not very sensitive, meaning that it won't pick up polyps, obviously, anywhere that you're not looking. So we usually say if you're going to get that study done, you got to keep going every 5 years because you don't want to wait long enough that you could potentially miss a cancer and then it turns into cancer. But if you combine the flexible sigmoidoscopy with one of these other stool tests, you can actually go every 10 years if everything is completely normal, which is kind of cool. The other camera study is called a true colonoscopy. I'll get to that in just one second. But there's also a CT imaging screening test, which is called the CT colonography, which is basically like a virtual colonoscopy in a way, is where you do the bowel preparation, which is actually the hardest part of getting a colonoscopy done. And then you just get a CT scan. So they puff some air inside of you, and then they just quickly scan your belly. And they are looking inside you for those polyps, for any little lesions that could be popping out throughout the colon and could be actually interpreted as a polyp or as a mass, like as a true cancer. And if those tests are positive, then you have to go for the colonoscopy no matter what, because now you have a high suspicion that something is hiding inside of you that needs to be evaluated and potentially taken out. And the only way we can take these out is kind of surgically through our little colonoscope. This is what a colonoscope looks like, what we use for a colonoscopy. I don't know if maybe we can get my pointer here. Let's see. So right here is the little handle that I would use to manipulate the scope. But then you can see there's a huge, long 1.5 meter long camera at the end of this hose. And this is what goes inside of you. They're actually not too bad, not too uncomfortable. If you've had some abdominal surgeries, it can definitely increase a little bit of that pain that you might have during the procedure. But if you have a good anesthesiologist, usually you don't feel it. And it's actually a pretty comfortable procedure, less than a half hour typically. But you can actually, we can actually put instruments through our channels on our scope, and we can go inside and take things out, take samples of it to look at it under the microscope. So it's a very cool procedural device, actually. And really during the procedure, all you're feeling is like a little bit of air, like I need to pass gas. It's a little bit embarrassing. People pass gas on me all day long, so I'm not offended. But it's actually a pretty quick procedure in terms of screening and not actually very uncomfortable. This is what a polyp actually looks like. It's a virtual kind of reconstruction. If you're looking inside of your colon, it's a big tube that holds poop, essentially. So this is what it looks like on the inside. This is the lumen of the colon. And polyps basically kind of form on the walls like this, like little kind of small, less than 1 centimeter masses that I can actually take a little biopsy forceps, which is probably the size of a tweezer, and I can go in there and I can pluck this off and look at it under the microscope and see, is this benign, meaning that it's not cancerous, or is this something that I know will eventually develop into cancer? As you can see in this picture here, they start very small, and if I leave that in there over 3, 5, 10 years, it'll eventually get bigger, invade into the wall, and then eventually become cancer that travels into lymph nodes, goes into your bloodstream, and actually gets throughout the body. And that's when you have malignant metastatic cancer. So colon cancer throughout the body at that point. That's what this is kind of showing you. But they start really small. So if you get that colonoscopy and we take these out, you're good for another 3, 5, 7 years, depending on how many you have. And then we can go back in and make sure that no new ones have now grown. And you can see that this is kind of the progression, starting as a polyp and turning into cancer. And really what that means is that if you nip it in the bud, meaning you take these out when they're precancerous, you're potentially creating an environment in your gut, in your colon, that is conducive to the formation of abnormal polyps and then eventually cancer. So even though we've removed the original polyp, because of your lifestyle, because of your genetics, because of whatever reason, you are prone to producing them. So we need to go in and periodically just clean you out and get rid of your kind of polyp to cancer transformation pathway that's going on inside your gut. So you can kind of think it as like spring cleaning every 3, 5, 7 years, which is it's kind of nice. And it's a pretty quick process. So definitely conducive for screening purposes to get this done periodically. So what can I do to decrease my risk of developing colon cancer? Obviously, if you have a family history, you have, a genetic mutation, it's kind of not really in your hands. At that point, you kind of just have to get screened and get treated. But if you don't have a family history, if you're otherwise considered average risk, you can still develop polyps, as I mentioned, because of your diet, your lifestyle, whatever it is. And they actually just did a study that showed that diet in particular and lifestyle can affect the development of colorectal cancer. So even though you have some risk factors that you can't change, you do have some lifestyle changes that you can make. And diet is actually now one of those lifestyles. So if you look, alcohol, wine, beer, cider, soft drinks, all the kind of high sugar, high alcohol things, as well as pork and red meat, these can all increase your risk of developing colorectal cancer. And that's now been proven. We've done a huge study looking at different lifestyle interventions and what actually affects the development of colorectal cancer. And then they specifically looked at the distribution of risk over these several categories. And generally speaking, people who drink a lot of alcohol tend to have more colorectal cancers. And then they also noticed pork and red meat have also increased that risk. But the good news is that there's actually a lot of diet modification that can be done that's conducive to health, to a healthy diet, but then also to decreasing your risk of development of colorectal cancer, like milk products, dairy products, calcium, magnesium supplements. Things that really mean a lot to me are fruits, high fiber, different, non-white bread, so high grains. Fortified breads are actually also really good for you. It seems like it has a lot of the vitamin B vitamins, phosphorus, just random multivitamin probably could actually help you in decreasing your risk of colorectal cancer. And that's actually pretty powerful. That means that you are no longer victim to your genetics necessarily. It means that you have some control over your risk, that you can actually feel good in practicing and focusing on. There we go. So then, obviously, we've done a lot about colorectal cancer because it is actually very prevalent in America and something that we can easily prevent. But there are other GI cancers that we can screen for. One of them is esophageal cancer. Esophageal cancer is, could be potentially genetic. You can have a family history of it. It can increase your risk of getting esophageal cancer. But typically the esophageal cancers that we're seeing are in patients who have longstanding heartburn or acid reflux. Obesity is a huge risk factor. These are modifiable. Like you can lose that weight. You can take medications to decrease your heartburn. You can change the food that you're eating to decrease that heartburn. Smoking and alcohol ingestion, another reason why you should maybe try to avoid that or minimize how much alcohol you do ingest, because these are huge risk factors for the development of esophageal cancer. And in fact, pancreatic cancer as well. A family history, actually Caucasian descent, and the age older than 50 years old are all risk factors. Those are non-modifiable risk factors, but they can lead to esophageal cancer. So if you have any of these and you're concerned, definitely go see your doctor, get a referral to a gastroenterologist, and get a screening endoscopy done, also called an EGD, an upper endoscopy, to look inside your esophagus and make sure that there's no high risk features that can increase your risk. Stomach cancer is another one that's not very well understood, actually, that we're currently looking into. Having a family history or a CDH1 gene mutation is what it's called. Those definitely increase your risk of having stomach cancer. But other things like autoimmune gastritis, or what we call atrophic gastritis, can increase your risk of cancer. Even having this H. pylori or Helicobacter pylori infection in the stomach is something so easy to treat that it's, you don't even need an endoscopy for this. You can just poop in a cup and we can check the cup to see if you have the infection, and then we treat you. But that's definitely preventable, a preventable risk factor for stomach cancer, which is kind of cool. And then if you've ever had an endoscopy and they've done biopsies to look for infection, to look for gastritis, and you've been found to have intestinal metaplasia, that also increases your risk of stomach cancer. And once you're plugged in, you just keep going to see your gastroenterologist and periodically get screened. And that's very preventative to then, potentially live a little bit longer, because you've been getting evaluations to make sure that you haven't developed stomach cancer. So just, knowledge is power here. Just knowing what your risk factors are, knowing what your symptoms are, you can prevent cancers. And I think that that's pretty cool. So next, really, I just wanted to kind of touch upon like what is considered normal. And I was kind of thinking about this question, and I was like, man, there's so much of the GI tract that it's really hard to talk about, like what would be normal. I mean, normal is not really feeling anything, not really thinking about your gut. And then I realized, a lot of your gut health can be gauged by your bowel movements. Like if you are having some sort of a disease, some sort of an infection, generally your bowel habits are going to change. If you have a new cancer, you're going to change it up. You're going to go from having normal bowel movements to being constipated all of a sudden. So these are kind of the things that are red flags, and I wanted to briefly review them with you so you can kind of keep an eye out on your day-to-day. So what is a normal number of bowel movements? And I get this question so much. Somebody could be having 3-4 bowel movements a day and think that that's normal for them, or having one every 4 days and they think that this is normal for me. But truly, if you have a healthy gut, you're having bowel movements up to 3 times a day and up to once every 3 days. That's considered a normal range. 3 and 3 is what I like to think about that. So if you're having any more than that, like 4, 5 bowel movements a day, that's actually abnormal, and that's considered diarrhea, and that should be evaluated. And the same thing, if you're having a bowel movement once every 4, 5, 10, 14 days, that is abnormal. And that's considered constipation, and should be evaluated as well, because there could be some intervention, some treatment that we could do to help you normalize. And also, not just number of bowel movements, but the consistency of your stool is very important. This is something called the Bristol stool chart. Basically there are 7 types of stools. Any harder and lower is considered constipated. And then anything looser or watery is considered diarrhea. And really it's just these 2 in the middle that are considered normal. A sausage shaped stool with cracks in the surface indicates that there's enough fiber, enough water, or even a soft, smooth sausage or snake-like bowel movement. These are considered normal. That means that you're hydrated. That means that you have good, healthy intake of fruits, vegetable, fiber, essentially. And that is the goal, actually. So anything less or anything more is considered abnormal. And what should you do about that? Stools that are runny, sticky, foul smelling, they could indicate that you're not absorbing food properly, that you actually might need to add more fiber into it to make sure that it's a little bit more formed. If it's watery, it could be infected and needs to be evaluated. Or there could be some inflammation in your body that's not allowing you to absorb your foods. And then when you toss in abdominal bloating, that might even indicate that you have an alteration or an abnormality in your gut microbiome, which is all the bacteria that lives inside your gut that forms healthy stools. You could have something called small intestinal bacterial overgrowth, also known as SIBO. And we can diagnose that, treat you with antibiotics, get you on a different diet, and things can get better for you. So should definitely be evaluated. And then, if your stools are hard, like I mentioned, with concern for constipation, still you might need diet modification to include more fiber, because now you're trying to loosen up and trap water inside your stool, and fiber does a really good job of acting like a sponge to get it softer. And then if fiber isn't enough for you, you're not able to get enough through your diet, you can get on a fiber supplement. You can, you can also start adding in stool softeners. And the way that I like to think about this is like mush and push. So, Mushing it is making your stools softer by adding a non-absorbable item like Miralax or Colace. And then pushing is kind of stimulating your gut to get rid of the stool. And that's what Senecot or Docalax would actually do. But constipation can be from poor diet. It can be from, not even good, reliable intake of food. It could be low residue foods like carbohydrates that get absorbed very quickly and don't actually provide any roughage to the inside of your colon, or it could just be adjustment from actually not emptying your bowels every day. This is a very common thing in the working person. You have a meeting at 8 o'clock and you have the pressure to have a bowel movement. You're like, I'm going to get in trouble if I'm not at this meeting. So then you hold it in. And if you hold it in enough mornings, eventually your body is kind of just adjusts and it's like, now is not the time that I'm supposed to be having a bowel movement. My body doesn't want me to do this. And then you adjust and you become actually anal retentive and you hold on to your stools, and then you develop constipation. And I've seen people not have a bowel movement for a month at a time. I mean, it's insanity. And then you have to retrain. If you now are not having healthy bowel movements, if you are constipated, that's where I come in and I help out, because you have to be retrained. So from a constipation perspective, if you have new onset constipation and you've always had regular bowel movements, or maybe you did have a little bit of constipation and now this is worse, you should be seen by your doctor. Especially if you're over the age of 40, we may need to go in there and make sure that you don't have a new mass or a new cancer hiding in there. That's the number one thing that I'm worried about when I see someone who now has a ton of constipation. But if you have always been constipated, you're taking over-the-counter remedies like Miralax, Colace, things like that, Docalax that are not helping, then you should go see a doctor, because you might actually have to retrain. And this is where you might need to get an endoscopy, make sure there's no mass, depending on your age, or you might even need to do this anal rectal manometry tool or a scan called an MRI to watch how you defecate, to see if you just need to be retrained. It's like potty training for the adult. At some point along the way, whether there was stress, diet changes, whatever it was, work, you need to be retrained now because you've developed a bowel habit that's not conducive to everyday life. Then if I do these tests, I might even be able to recommend pelvic floor physical therapy for that retraining. If it's very severe, rarely we might even need to do surgery to help you regulate your bowel habits, or even just diet modification, which is very, very easy. So these pictures, I'm sorry, are a little bit disturbing. They're very medical. So if that bothers you, I just wanted you to be able to look away. The number one thing, I'm sure you guys have heard of the squatty potty, is positioning. If you're not pooping in the proper position, you may not actually be activating the muscles that are necessary to evacuate your stool regularly. And that's why you can see here, this angling, this is a little bit too acute, meaning that it's not like straightened out enough to allow stool to pass easily. So stool may be getting stuck in this angle and not allowing you to pass it properly. And you can see this is the way that you need to angle your pelvis in a squatting position to be able to pass stools easily. And this is not him squatting into a small toilet. This is probably him sitting on the toilet with a squatty potty underneath his feet to raise his angle a little bit more straight. We can also do MRI defecography, where you can see this angling again. They basically give you an enema, and then they watch you have a bowel movement, and they're trying to see, is this angle being fixed in the right direction so that you are able to open up your pelvis and allow stool to pass. And alternatively, if you have incontinence, we still do this imaging because we want to know, are you passing stool too quickly? Is there some sort of a musculature issue? Something is not activating the way that it should to keep stool in? Does it just slip out too easily? These are all things that we need to, these are our tools that we need to use to be able to diagnose you and help you. Anal rectal manometry, this looks a little bit complex, but really it's a balloon on the end of a long sensor. And this goes into your rectum, and it really helps us figure out how are the rectal muscles contracting and how is your anus essentially coordinating you to have a smooth bowel movement. Same thing for both incontinence or for constipation. We're able to target muscles and see if we can help you retrain. And that's where the pelvic floor physical therapy comes into play. If all of this is normal, then it's most likely a musculature issue with the colon itself, or it's a diet issue actually. So that's very helpful for us to know. So just to kind of wrap it all up, bottom line, when should you see your doctor? Whenever you are uncomfortable about what you're feeling from a GI perspective. whether you're nauseous, you have bloating, you have irregular bowel habits, you don't know when you're going to get diarrhea, don't know when you're going to get constipated. Anytime you're uncomfortable with your GI tract, you should see your doctor and ask about it, because there's most likely some either problem going on, or you can get some reassurance that this is something that we can fix with diet and medication. If you ever see blood in your stools, this is completely relevant to this program, or you actually see black, sticky, tarry stools, like as if someone is paving your driveway, you should see your doctor, because that is the sign that you are losing blood in your GI tract. I can't tell you how many people I meet who have black stools for so long, and then by the time they come and see me, their hemoglobin, which is a marker of anemia, is 3, 4. I mean, super low, like at risk of causing a heart attack low. So it's very important that if you ever see blood in your stools or black stools, that still counts as stool being, having blood in it that's trying to get broken down. You should see your doctor, because you may actually need an endoscopy to rule out a bleeding blood vessel, an ulcer, a mass, anything like that that could be leaking blood into your gut. Very important. Or, as I mentioned many times, a change in your bowel habits. That's a very big deal. Could indicate inflammation, could indicate a cancer, a malignancy, anything like that. If you have a change from your baseline, it's been going on for at least a couple months, you need to go see your doctor. Of course, you would probably go see your doctor anyway if you had abdominal pain regularly, a poor ability to tolerate things by mouth, to eat anything, drink anything, or even just all of a sudden having a lack of appetite, which could actually lead to unintentional weight loss. That's potentially a sign that you have something bad going on. I mean, a lot of people love to lose weight, but this is not the kind of weight that you want to lose. You want to lose weight by changing your diet on purpose, by working out. You don't want to lose weight just by living. That means that there could actually be something going on inside of you. So with that, I just wanted to say thank you again for allowing me to speak to you and meet all of you. It's been such an honor, and I look forward to working with you. And then if you guys have any questions, go ahead and ask, I guess. Thank you.
Thank you, Dr. Taneja. She has just a few minutes to take some questions, because I know she's got a prior commitment. So if anyone has any questions.
Videos on.
I don't know, Deborah, if you can, is it, someone's got their hand up, Mr. or Mrs. Smith, Jovan Smith?
Hi, thank you, friends, for coordinating this, and thank you, doctor. So I've seen a lot of ads on television about these at-home, like Cologuard, these stool tests. So I'm wondering if you can give us any insight about if that's recommended, or if it's best to, I mean, I know it's always best to see a doctor, but what's the take on those at-home tests?
They're pretty good. I mean, Cologuard is recommended as part of screening. But as I mentioned, Cologuard advertises itself as being good, meaning that if it's negative, it's good for 1 to 3 years. You don't need to get another stool test. But as I mentioned, there is a little caveat that if you do wait the 3 years, the sensitivity of the test does go down a little bit. And it's not recommended to wait the full 3 years to get that test done. But if it's more comfortable for you to do the test at home, mail it in and get the result, that is totally fine. It is recommended by the U.S. Preventative Services Task Force. And then if you submit it and it's negative, you're good for 2 years. But we do consider colonoscopy the gold standard, because not only do we find the polyp if it is there, but then we can just take it out at that time and then move on. And you don't have to get it done for 5, 10 years if it is truly negative. There is a little bit of a polyp miss rate, up to 10% actually, but it's still considered gold standard of finding and removing polyps or precancerous lesions. Yeah.
Great. Thank you for that question. We have a question from Rebecca C.
Rebecca.
Yes, hi, hello. My camera is not working, but I'm here. I just have a question. So my mom suffers from gastritis a lot. So she takes Dexilan every morning, and they recently found ulcers in her esophagus. Can that lead to cancer in the future?
It depends on what the ulcer is from. But the short answer is yes, potentially it can. Chronic inflammation in the esophagus definitely increases your risk of developing cancer. The good news is that usually if you get this procedure done as a screening after the age of 50, and there is no real high risk features, then you actually may not be at high risk. If the area next to the stomach, which is called the Z line at the bottom of the esophagus, is normal, you actually don't really have a high risk of getting esophageal cancer at that area. But it depends on what's going on with that ulcer. Like if you are on Dexilant, it sounds like, and it's been working for her to decrease the risk of further inflammation in the stomach, then maybe she needs a higher dose, or maybe she needs like a coating medication to coat that ulcer so that it heals a little bit faster. But generally finding ulcers that don't have an etiology is potentially bad news, and that could increase your risk of having cancer wherever the ulcer is, and that might require a little bit closer surveillance. But if it's a matter of just increasing acid suppression or treating an infection, then you may not be at higher risk once you kind of get the acid and the infection under control. So that would be kind of an individual discussion I think that you would need to have with your physician.
Okay, thank you so much.
Yeah, no problem.
Appreciate it.
Thank you. I got another question from Louis Diaz. Are you with us, Louis?
Yes, doctor. Thank you so much. Appreciate your time for
no problem.
explaining all this. Thank you. From the hospital liaison committee for Jehovah's Witnesses, and this only happened maybe 2 or 3 times in a couple cases that I've been involved in, and it just left everybody with kind of like Wile E. Coyote, the cartoon, with the question mark above his head, what just happened.
Yeah.
Even the doctors, and I'm bringing this up because you participate in education of this particular disease or gastrointestinal disease. Basically, it was bleeding in the colon, heavy bleeding. They did. The individual ended up in the hospital, obviously, hemoglobin down to 3 or 4. And they did a colonoscopy, went in there, they wanted to wait and see if they could stop the bleeding, see what they had to do, if they had to cauterize something or whatever they could do, if it was some kind of cancer, so on and so forth. Every time they went in, the patient was clean. There was no visible bleeding. And I kid you not, they did this like 3 different occasions. And they went in like 4 or 5 times within a 6 to 8 hour period. And every single time the doctor's like, I don't see anything, but we know she's bleeding. We've seen the fecal matter. Is there something that comes up in your realm, as an educator in this, that what it could be? Is it just one of those things where, maybe coagulation just took place and the body's trying to recuperate? Meanwhile, she's being given blood enrichment therapy, hemoglobin went up. 2 days later, she left the hospital, but it happened 2 or 3 times, and it was kind of interesting to see that.
No, that happens so commonly, actually. I mean, we end up getting those patients because we are a tertiary care hospital. We do have the resources that we need to evaluate for GI bleeding. And you wouldn't believe, I mean, so many patients come to us and we just cannot find what is happening, but they are definitely still bleeding. But you're absolutely right. Usually these bleeding events happen from very tiny little blood vessels called AVMs, AV malformations, which is where the artery and the vein abnormally form, but then they bleed and then they disappear like into the mucosa. So then when we go in with our cameras, we actually don't see that lesion. And you're absolutely right. We have to do these endoscopies 2-3 times, and it's a series. We do the upper endoscopy, we do the lower endoscopy, and then when we don't see anything, we actually have to have the patient swallow a little capsule to look at all the small intestine that's in between, above and below. And we do this like 2-3 series around, and then eventually you might even find something, one little abnormal blood vessel, or you might even mix in some imaging study in there to catch really small bleeding. And then you kind of know, this is an area that needs to be what we call embolized, or blood needs to be cut off to this particular area of the gut to try to control this bleeding. But this happens very, very commonly for our university setting. I don't think it usually happens too much in the community in general, but definitely these are challenging cases, and we keep them in the hospital until they're truly safe to be discharged, especially at such a low hemoglobin. We don't want them to really bleed anymore, because then they could potentially have a significant cardiac event. So No, yes. So this happens a lot, and we utilize pretty much everything, our surgeons, our interventional radiologists, imaging modalities, we're constantly chasing this bleed until we're confident that we've gotten enough of it. Yes, exactly. There's also diverticulum of the small intestine, somebody mentioned. You can get all kinds of crazy pathology that leads to a hidden bleed. So we keep a very close eye on it, and we do as much as we can, to try to help the patient out with also all these kind of support mechanisms for their hemoglobins.
Thank you, doctor. Appreciate it.
Yeah, no problem.
All right, thank you. Dr. Taneja Sharma, we want to respect your time. Is it okay if we take one more question?
Yeah, I can definitely do one more question. Thank you.
Okay, one more question. I think Arlene Freeborn had a question.
Yes, and thank you very much, doctor. In fact, what this brother just mentioned happened to a patient, one of our members in our congregation. They never did find out why he was bleeding so much. They put him on hospice. They sent him home. He made a full recovery and he's doing well. So it's still a mystery.
Yeah.
My question was, colonoscopies, 5 years in between. First time I had one, they found a polyp, removed it. Second time I had one 5 years later, they found 2 polyps. Should I be letting them wait 5 years, or should I be doing this every 3 years?
It's interesting that we've actually researched this particular question a lot, and we've had a recent update in our guidelines. And I have a feeling we're probably going to go back to the old guideline, but generally speaking, it depends on how big that polyp is, how many of them there are for sure, and then what type of polyp is it? Is it like a hyperplastic polyp that's actually not considered precancerous? Is it a type of hyperplastic polyp that could be part of a syndrome that you can't actually test for? You just have to remove those polyps. Or is it part of an adenoma series of polyps? Is it an early adenoma? Is it an advanced adenoma? Those all get considered in when should we recommend another colonoscopy. And generally speaking, if the polyp is large, or if there's more than about 4 or 5 of those polyps, you actually want to get them done around 3 years. Even if you have a larger polyp that's between 1 to 2 centimeters, which is pretty sizable, actually, that's like my limit as to what I feel comfortable removing from a colon. The next time you need to repeat is actually, 6 months after you remove it, if it's large enough, but then 3 years to look for other potentially precancerous polyps. If yours were small though, like less than a centimeter, and they weren't considered advanced adenomas or something kind of concerning for a syndrome, you can probably wait at least 5 years before getting another colonoscopy. And the newest guideline says 7 to 10. So even less frequent. A lot of gastroenterologists don't actually feel comfortable with that 7 to 10 year recommendation. We feel like we've shown plenty of times before that an adenoma could actually develop and progress pretty quickly over 5 years. So a lot of us don't actually follow these newer guidelines that say that you can wait, 2 to 3 years longer. But it's okay, generally speaking, if the polyps were small enough, even though you had 2 of them, to wait 5 years. It's actually not considered too high risk, but definitely if they were bigger or considered an advanced adenoma, I would have to look at the pathology. Then usually we can recommend a sooner interval, like around 3 years.
Thank you very much.
Yeah, no problem.
Thank you, Taneja, Dr. Taneja
Thank you
Sharma.
so much, you guys. It was very nice meeting you, and thank
Do
you for all your
mind, there's a
questions.
few more questions. If you don't mind, I'll if you
Yeah,
can
email
read
them to me, and I'll get it back
get
to
them over
you.
to you.
Yeah.
Thank you so much.
Yeah, no problem.
Again,
Thank you,
real
guys.
practical information.
Thank you.
Yeah, takeaway for me here is obviously preventive medicine. Get your screenings done. Pay
Yeah.
attention to your symptoms. Pay attention to your poop. I know it sounds funny.
Yeah,
but
look
pay
at your
attention.
poop. My patients don't look at their poop enough. Just before you flush, just take a peek and look
Yes.
down. It's so much
And-
helpful information.
Yes, and men, don't worry, get your colonoscopy done. I know that's
You'll be
taboo for
asleep, and it
men.
won't be embarrassing, I promise.
Yes, so please.
It's
you gotta-
only
you gotta
doctors
get
in the
that.
room.
Early access and preventive medicine. Thank you so much, Doctor.
Yeah, thank you,
Appreciate it.
guys. Very nice to meet you.
Very good. So we're going to go into my program or my presentation briefly, and then we're going to have Cecilia also talk to us about our Verdugo Hospital. But Deborah's helping me with the slides. So thank you. Thank you again for connecting with us. And we want to respect your time. So we're going to get through this pretty quick. I am Alex Perez. I'm the manager for our transfusion-free and patient blood management services at Verdugo Hills Hospital, over at Keck Medicine, over at Keck USC, and also at Norris Cancer Center. So it's a privilege for me to be speaking to you. Next slide, please. So what I wanted to talk to you about, this is fairly a new program over at Verdugo Hills. We're following the same footprint as we do at Keck and Norris, which we've had a program there for over 20 years. And two things that I want to just share with you in regards to accessing our transfusion-free services at USC Verdugo Hills. One of them is to contact us. So please take advantage of the resources that you have. Obviously, you have Randy Henderson, who's our director, and you have me managing specifically also over Verdugo Hills. So please contact our service so we can refer you to the proper physician and then help you navigate through I call it the forest of insurance. So sometimes it can be very difficult to understand. Believe me, it's difficult for me sometimes to understand it, but you have a partner that will help you navigate and get you the access that you need. And then secondly, you really want to align yourself with a transfusion-free service. And that would be also USC Verdugo Hills Hospital, which is part of the USC family. Choose it as your home hospital when you're looking at your insurance, especially your commercial insurance. And align yourself with a physician also that will visit you at Verdugo, or a specialist at Verdugo Hills Hospital, as well as Keck and Norris, but specifically Verdugo Hills because it's in your community. You really want to align yourselves with them. How do you do that? You can reach out to us at our office and we can help you with that. And one of the ways you can also align yourself with our program is using our emergency department. We have an amazing staff there at emergency department that also has a stroke center. And we're able to help you and fast track you into our facility. The hope too is if it's something that needs a higher level of care and insurance is hopefully willing, you will be sent over also to Keck Medical Center for higher level of care if it's needed. So that's the advantage of seeing us there. You have our transfusion-free staff there also, where we can definitely help you. Next slide, please. So I wanted to share with you briefly what we do at the hospital side, because sometimes you don't get a chance to get an eagle view of what we do to help our transfusion-free patients. I wanted to show you what we do at the nursing level or the nursing role. As a matter of fact, every entry point to our hospital at Verdugo Hills Hospital, we strive to properly identify our patients, especially our transfusion-free patients. So that's why you have on there proper identification. We want to obviously do proper documentation, communication within the staff, which means communication also to our staff, so we know that you're there and we can respond appropriately. And then obviously patient support, because the culture, as just like at Keck Hospital and Norris, at Verdugo, our culture is of acceptance, and we are familiar with our transfusion-free patients, especially our Jehovah's Witness community. Next slide, please. So one of the things we wanted to show you is one of the inner workings that we have. When a patient comes to our hospital, if they go through the emergency department, if they're going through to our pre-op because you're going to have a procedure, if they're going through our admitting area, you'll notice there on the right, one of the things that is asked is, if medically necessary, would you consent to a blood transfusion or blood products? That's really a screening tool that we actually created so we can properly identify our patients that do not want blood transfusions in their care. So that is key, because when this gets clicked off, it acts as a safeguard for our patients. So if any provider were to try to order a blood product, or what they call a type and screen and type and cross, which is to prepare a patient for a probable or a potential transfusion, it actually creates a warning screen or an alert screen on the computer, letting them know, take a pause, this patient is a transfusion-free patient and you need to confirm. So this is one of the safeguards that we use, and we wanted to show you that. So if you ever come through our hospital at Verdugo Hills, USC or Keck or Norris, whether you're coming in for an appointment with a dermatologist or you're coming through the emergency department, you will be asked this question. And that's one of the key questions we ask our patients. And this is what really was implemented for our transfusion-free service at all our hospitals. Next screen, please. You'll notice that once this question is activated on the main, what we call power chart, which is what we use on the main medical clinical screen that our physicians and our staff sees, right under allergies, which is really important, is blood transfusion acceptable to the patient? And obviously, if you're a transfusion-free patient, you're going to see a no there. And that means that that is activated, and that's one of our safeguards that is in place. So that's how we talk about, that's what we talk about, proper identification and documentation. Next slide, please. Another thing that we do to document and make sure that our patients are formally transfusion-free and documented is our blood refusal form. This is the one that we use that's based on the state of California. And if you go to the next slide, we can take a closer look. So when you come into our facility, this is one of the forms that you'll be prompted to fill out, really to sign after you've read it. And if you agree with it, hopefully sign. This is our blood refusal form. And basically you're stating that you do not want blood transfusions in your care. You understand the risks that are involved. And this really complements your refusal when you say, no, I don't want transfusions in my care. And it also complements your advanced directive, your no blood card. And that's one thing that we want to make sure that you have in place and that you also show us when you come through the hospital. So this will actually complement your refusal of transfusion. We have this form also in Spanish. And because of our growing Armenian community in the area, we're looking also to have this form in Armenian. But obviously we have our language line system. So anyone that comes in under any language, we're able to help and actually translate this form. Next slide, please. Another form that we use that you may be familiar with is our transfusion-free product treatment and procedure form. If you go to the next slide. This form is another form that we use so we can understand what other items you may or may not accept. Everything on this form is acceptable to a Jehovah's Witness patient, for example, but some may not want them. It is a personal decision matter, or what the witness community calls conscience matters. So you have the top portion that goes into items that are minor blood fractions, which are technically proteins. And then the second half, you have the use of machines or apparatus that involve the use of your own blood. So these are items that, even though it's our laundry list of items, and even though you may not be needing any of these, whenever you come into the hospital, we ask our patients to please fill this form out so we understand better what items you are able to accept, or what items that you are not comfortable with, which you will not accept. And we have educational material, obviously, that we share with our patients. If you go to the next slide. We have educational material that we give so patients can better understand what these items are. What is albumin? What is erythropoietin? What are immunoglobulins? What is cryoprecipitate? And all these items that would be a matter of a personal decision for a witness patient. So it's really important to do your homework beforehand and understand what items you are comfortable with. That way you can speak to them intelligently, because really it's not good enough to just say, I don't want transfusion. No, you have to understand how to explain that. You have to be able to say, well, when I don't want blood transfusion, that means I don't want any red cells, platelets, or plasma, or white cells, because those are the four main components of a transfusion or of blood. Anything aside from that would be an alternative or a fractionated product like the ones you see on the screen now. And it's really important to understand what these are. That way you can choose and be able to make an informed decision if any of these things are to be offered to you. Next slide, please. Another thing that we use, obviously, when you come in through the hospital and you identify yourself as a patient that does not want transfusion and you sign a blood refusal form, we will immediately band you with one of these beautiful plastic jewelry pieces that we have. Just kidding. But sometimes you end up with several bands. You got your white one that identifies you. You've got this green one that identifies you as a transfusion-free patient. If you're a fall risk, you'll get a yellow one. So we call it jewelry. But this is really important because this is also, again, another safeguard that we use at the hospital level when you identify yourself as a transfusion-free patient. Next slide, please. And then you go into your chart. This is what your chart looks like. Our charts are different colors at the hospital. Typically, they are a cardinal red color. But for our transfusion-free patients, these are exclusive to them. These are the charts that we use. It's, again, another safeguard, another alert on the floor, the hospital floor. And as you can see on that sticker, it's pretty pretty informative as to what this patient will accept and not accept. And this prompts anyone, whether it be a nurse, whether it be a technician, whether it be a physician, and they're looking into this chart. Now, the soft chart also has not only your blood refusal form, your product treatment form, a copy of your advance directive, but also this chart indicates that you're a transfusion-free patient. So I wanted to share with you just some of the safeguards that we use at the hospital level. Obviously, you have me going around and auditing and making sure everybody's taken care of also. We have good communication with our nursing staff and our managers. So whenever there's a transfusion-free patient that comes through, we make sure that all these things are in place for your protection and to make sure that we honor your wishes. Next slide. So you can really only take advantage of these things if you reach out to us. So that's really important. So if you feel that you are looking for a new physician, you're looking for a specialty, you have any type of need, you can see there's most of our services right there. I've highlighted the emergency services because Keck, USC, and Norris does not have an emergency department. So really your gateway and your door to our USC system is through our emergency services. So please take advantage of them. We've got a very experienced staff there. And I also highlighted women's health because over at Keck and Norris, we don't have maternity and we don't have an NICU or a NICU for babies. At Verdugo Hills, we do. Again, that is your gateway into our transfusion-free services. So I really encourage you to please reach out to us. If you have any questions of any type of specialty, any questions in regards to how to gain access, for example, if you're having difficulties with your insurance, or anything that, any question that you might have that's medical related, we'd love to be able to help you and help you navigate because it can get complex. And that's my song and dance for today. Any questions that you may have in regards to?
Oh, sorry. I accidentally muted you, Alex. I meant to unmute myself. Sorry. I see that Mr. Ritchie has a question.
Yes, Mr. Ritchie, please.
Can we get those forms emailed to me so that I can go over that with patients at home before they drive up there?
Sure, I'd be happy to share that with you. We actually have the Keck version of that on our website.
Okay.
And if you don't mind reaching out to me, or I could take down your information, I'd be happy to send that to you.
Okay.
Do you have a way to get a hold of me?
Yes, I'm sure I can text you.
Okay, very good. What I'm gonna do is I'm gonna take down your name right now, Lou Ritchie, and I'm gonna reach out to you, okay?
Thank you.
Yeah, thank you.
We also have Arlene Freeborn has a question.
Yes, Arlene.
Hi, Alex. Thank you always for taking good care of me at USC, by the way.
Oh, you're welcome.
I do have a question about the erythropoietin. I had heard that they were coming up with a synthetic erythropoietin that was not laced with human albumin. Did they ever achieve that?
Great question. I actually talked about you yesterday. We actually have that available at our facility now. It's a product called Redicrit. Redicrit does not have human albumin in it. And these are one of the things that we actually, I'm speaking to my director, Randy Henderson, yesterday. It's one of the things that we're striving to help for our facilities to obtain and put on the formulary products like this that don't contain a human element to it. So we actually have Redicrit right now. We're actually looking into other items that would also be substitutes to the products we have now that contain a human element to it. And what I mean by that, I mean minor blood fractions. But yes, we now have Redicrit that we're using, which will be a substitute for erythropoietin. The brand names are Procrit and Epigen, to be able to use and not worry about having that fractionated product in there.
Thank you so much. That's excellent news.
No, my pleasure.
And Lloyd Thompson has a question.
Yes, I'd also like a copy of the documents that you showed, and I'd like to have you spell Redicrit.
Sure. You know what? I don't know if I have it spelled correctly, but I can definitely send it to you. I
Okay.
spelled it Redicrit,
What I have.
Okay,
but I might be wrong, so don't quote me on that, but
okay,
I'll look it up and send it to you, okay?
okay. So you got my email address, right?
So I took down your name and I'm gonna look it up and find
Okay.
you. Thank you so
Okay.
much.
Thank you.
Sue O has a question. Mr. O.
Yes, so I was wondering, is a Ridocrit, how often is it given, and how is that? How does that compare with Aranesp?
Good question. To be honest with you, I don't know. I need to research it myself. I just found out it was on the formulary at our facility. Great question. I'd be happy to get back to you and send you that information.
Okay, thank you.
Thank you.
Yeah, Rebecca C has her hand raised.
Yes, I would also like the forms, if you could send them to me, Alex, please. I'm trying to update my DPA card.
Sure. And who's
Please.
this? I'm sorry, who's this again?
Rebecca
Rebecca,
Chaqueco with a C.
Rebecca C. Gotcha.
I'll
Sure, sure
update
will.
my name right now on the
Okay, great. Thank you.
participants.
I'll send that
Thank
to you. Yeah, this is actually, you brought up a good point, Rebecca. You can use these terms to add them to your advanced directive. And I always advise our witness patients to, in your advanced directive, in that big space you have right there,
Yes.
you can put on there, I will accept items such as albumin, immunoglobulins, and the use of machines or procedures such as cell salvage, hemodilution. That way, when a physician sees that, they understand the family of products that you're okay
To
with.
remember that.
Yeah, so that's really important to do that,
Sorry
because
about
when you
that.
think about it, when a patient says, I don't want blood, they'll, immediately the physicians think about the red stuff. They think
Yes.
about red cells.
Yeah.
That's why a lot of times the follow-up question is, okay, will you accept plasma? And if you don't know your stuff, that will trip you. So you need to be able to say, well, I don't accept red cells, platelets, plasma. And if your conscience allows, you can tell them, I do accept albumin and the other fractionated products. Because when you think about it, red cells, platelets, plasma are also fractions.
Yes.
But they are major fractions of blood. But for a witness patient, they will accept minor fractions. So you need to be able to say, okay, these are the fractions I accept, not red cells, platelets, plasma. So you really have to be educated and be able to speak to that.
So the terminology that on the forms, we could just transfer those terms in our DPA card, correct?
Correct. If
Jehovah's
those are items
Witnesses?
that you accept, you can definitely use those terms.
All right, I think we have a question from Martha, who's been so patient. Didn't get her question answered while the doctor was on, so go
Oh, I'm
ahead,
sorry, Martha.
It's
Thank you
okay.
thank you very much. I would like to receive the information that you have available that you showed us.
Sure. You guys are giving me homework. Okay, Martha Sanchez, thank you. I'll look you up.
Thank you.
So,
And I think
maybe it might be beneficial, Alex, if you just send it to the group. So
Sure, I could definitely do that.
that way then everyone just,
Good idea.
yeah.
Easier.
and I think Edgar Berrios has a question.
Yeah, that was my question. If you can send the information, but since you just mentioned send to the group, and also the name for the new substitute for the erythropoietin, if you can find the name, I would
Surely.
really appreciate it.
I will follow up on that. Thank you.
Thank you very much.
And we got time for one more?
I think Mr. O has a question, another question? maybe?
Yes, I was wondering, so how was your the cardiology program?
So Cecilia, you want to speak to that?
Yeah. Are you talking about in terms of Verdugo Hills Hospital or the health system as a whole?
The Verdugo Hills Hospital.
Okay, so we have an excellent cardiology department. It is comprised of both Keck faculty and also community physicians. We have the benefit of being a community hospital, so therefore we have both sides, the academic and then also the community. So we have both. So many of our community physicians see patients who come through our emergency room or who get admitted and then are referred to them. But for any higher level of care, then of course physicians from Keck then would be called in for any higher level of care.
Right.
We're in the process right now of building an interventional radiology catheterization lab. So that will be completed by spring of next year, probably be open by late summer, but that's something that we're doing. And again, it will benefit the community. It will benefit all of the patients who come to Verdugo Hills Hospital.
Okay. And you also mentioned you have a NICU unit over there?
We do. We have a neonatal ICU. It's a level 2. And when we've only really had to transfer out to Children's Hospital, maybe since we've had it for about the last 3 years, I'd say maybe about 4 times, not very often. So it serves the purpose of our community.
Oh, I see. So what's the earliest of a gestation that you
32 weeks.
32 weeks. Oh,
Yeah.
so anything below that, you're gonna have to go to
transfer.
HLA.
Yeah.
I see. Okay, 32 weeks.
Right, thank you. Great question. That's because of the level of NICU that we have.
Yeah.
Great. Thank you
Level
so
2.
much.
Now,
Thank you for
I
your
will add that we are in the plan right now is to increase that to a level 3. And we will be starting on that probably in the spring of next year, so 2022. And so hopefully by summer or fall, it will be licensed then as a level 3.
Okay, thank you.
You're welcome. Great.
Thank you. And you know what? I'll go ahead and introduce Cecilia. Thank you, Cecilia. I know you've been already answering
Thank
some
you.
questions, but
Oh, that's
Cecilia
all
is our director of business development and is really involved with our community. So please present to us and let us know what are the new happenings there at USC Verdugo Hills Hospital.
Okay, well, thank you, Alex. And it's been a pleasure working with you on the transfusion-free program at Verdugo Hills Hospital. So who is Verdugo Hills Hospital? So we are the community hospital for the health system. We've been now part of the health system for the last 7 years. We're located in Glendale, California, and we're right at the 2 freeway and the 210 freeway, sort of where the two of them join. We're a 158-bed hospital. And as I said before, we actually have academics, but then we also have community medicine. And there are several departments that I wanted to highlight today for you. One of them, of course, is what Alex had brought up earlier, which is our emergency department. It's open 24/7. Our nurses have received a prestigious Lantern Award for best practices in nursing. Our physicians are the same physicians who rotate through LA County Emergency Department as well. So what you're getting then is the best of the best in emergency physicians. We have a OB department, so we deliver babies. And we also have a neonatal ICU unit, and that's for babies, of course, who need a higher level of care. We have a gastrointestinal lab. So as Dr. Taneja had said earlier, when she put up some of the diagnostic testing that's available, we do everything except for the CT colonography right now. That we do over at Keck, but we are going to be bringing that to Verdugo Hills Hospital within the next 6 months. We do surgeries, of course. We are the only community hospital right now who really puts a lot of emphasis on technology. We have a robust robotics program, And we do, of course, prostate and kidney surgeries using the robot, also GYN oncology services as well, general surgery and thoracic surgery, all using the robot. We also have some other higher surgeries, such as what's called aquablation. That's using a water jet rather than having surgery for prostate. And then we also have what's called HIFU, high intensity focused ultrasound. And that's also for prostate. We have a robust orthopedics department. We are recognized as a center of excellence for hip and knee replacement. So you can be ensured that what we'll be doing is offering the best in orthopedic surgery. We'll usually patients for hip and knee replacement, sometimes they stay, sometimes they don't. But our whole emphasis is getting you walking within the same day of the surgery, so that way you have better mobility and of course a faster recovery as well. We have urology, and our urology department is run by the USC Institute for Urology, that is ranked #9 right now in the country. The office for urology right now for Keck is right on our campus, and they are always taking new patients. They have about 15 physicians was my last count. And they treat both men and female, male and female. Alex mentioned earlier, we have a stroke center. We also have a wound care center. We have a hyperbaric chamber. So that way we are able to treat wounds using a hyperbaric chamber, which of course what that does is it helps them to speed up the process for healing, and that's on our campus. We also have a limb salvation program. So what we try to do is, let's say you have diabetes and you have some wounds that just are not healing. We try as hard as we can to put you through the limb salvation program first, to make sure that we can go ahead and preserve the limbs. Physical medicine, rehabilitation, speech therapy, occupational therapy, and so forth. Pelvic floor therapy. We have therapists who are certified in pelvic floor. That again is something that is very unique to a community hospital. We have a foundation, which Deborah Warwick, who today is running our presentations and so forth, is part of. They're the fundraising arm of our community hospital. And they're doing an extremely good job of raising funds for our IR cath lab. They did it for our neonatal ICU unit. And we have a women's council. And it's a very unique thing to have at our hospital. We also, through the foundation, we have a group of physicians. It's called the Caduceus Society. Caduceus is actually fundraising physicians. So it's our physicians who actually go out into the community and fundraise because they feel so passionate about the hospital. And again, it's not something that you really see out there in the community, not even in academics. And let's see, staying safe throughout COVID. We have, throughout the pandemic, have been at the forefront of making sure that we have remained safe. We were safe for our patients, safe for our employees, staff, nurses, and our physicians. So much so that many of our areas, practice areas, the physicians all said, we're bringing our patients to Verdugo Hills Hospital because they have shown us that they follow the best practices for utilizing PPE, which is of course the masks, the face shields, gowns, and so forth. Our emergency room, everything was separated. Of course, now it's still separated. We still go ahead and screen, making sure that someone who has symptoms and so forth takes a different pathway in a different area, while we go ahead and evaluate them from other patients. And we right now are participating in vaccinating the community for COVID, and we're vaccinating right now 12 years and up. So all of this has really been the success of Verdugo Hills Hospital for the last 7 years for the health system. We're looking to add another community hospital. We are in what's called the due diligence phase for Arcadia Methodist Hospital. And we're hoping to hear maybe by the end of the year, first part of next year, if they will be joining the Keck community hospitals. So again, I wanted to thank you very much. And if you have any questions, I certainly am here to answer them. And thank you, Alex and Deborah, for today. You guys were awesome. Any questions? Nope. All right.
Thank you, Cecilia. We appreciate
Yeah,
you.
uh-huh.
Any questions for Cecilia? I think it was really clear, and thank you. I know Cecilia wanted to have some slides, so but she
Yes,
knows.
I'm sorry,
she
I
knows
had
the
to
stuff. She knows the stuff.
have technical difficulties this morning with my slides. So.
But no, we know you're amazing. So thank you so much. Yeah, Cecilia's done so much for the hospital, and so we appreciate all you do. Oh, we do have one question. Two questions. Here we go. Lloyd Thompson, do you have a question?
Yeah, we're up here in the San Jose area. That's great hearing about Verdugo Hills, but you realize that's 400 or 500 miles away. So do you recommend any particular facility in the San Jose area, like El Camino Hospital or Good Samaritan?
I don't recommend you come all the way down here.
Yeah. Yeah, I'm not familiar with those hospitals, but what I do have at my disposal is to look at some of their ratings and so forth. So I definitely can go ahead and take down your name and send you an email. Okay.
Great, great.
Thank you. What I recommend, I mean, obviously, if you're close by and you can come into the emergency room, I recommend that. If it's an emergency and you know it's an emergency, you need to dial 911. That's very important.
Yeah,
We've been there, done that.
Yeah, and if you're close by, we definitely want you to come here. I know we have some patients that sometimes will make their trek from Fresno or Bakersfield to come down here because that's the confidence that they have. But I get really wary about that. And that's not recommended, especially if you feel this is an emergency. But I do, if you're if you're that far away, I do recommend you lean on the hospital liaison committee for Jehovah's Witnesses in your area and ask them where it would be the most cooperative physicians or emergency department that you should go to.
We're familiar with them.
Okay, great, because I know they usually have the heartbeat of what's going on in the area, and they're an amazing resource. So please lean on them.
Yep, indeed.
Thank you. And a question for Rick Garcia.
Rick Bruns? Oh, Rick Garcia. No.
Yeah.
Rick Bruns.
Alex, this is for you or for Cecilia. When we speak about doctors, are we talking about doctors who work under the umbrella of transfusion-free only? And I have two questions.
Sure. So we have our transfusion-free physicians that actually we seek out the physicians that want to and have the experience of working with transfusion-free patients. And those are the ones that we recommend to. So for example, you listen to Dr. Taneja, even though she's pretty new to us, she actually has a lot of experience working with the witness community. She comes from back east and has quite a bit of experience, and just recently was working with some patients that had some extreme anemia. So when we speak to them and we put them as part of our panel, we really interview them and make sure that they have the experience, and so we can work with them. Not every patient, or excuse me, not every physician has the experience, but the ones we refer to and the ones that we're working with definitely have that experience.
Okay.
You get another question?
My second question was, what is a threshold in determining whether or not to go with a orthopedic surgeon or a neurosurgeon when it comes to spine surgery?
Ooh, you know, that, yeah, and it's a good question because they overlap and they do the same, you know, type of surgery. I always tell people that it really depends on what type of pain that you are having. One might be from nerves, which of course then would be seeing a neurosurgeon, and other might be bony structures, which of course would lean more towards orthopedics. But I would say first and foremost, of course, going with someone who is going to be following with the program. But it might be good that if you get a second opinion from someone, you know, either the ortho or a neurosurgeon, so that way you can see what their plan of treatment would be, whether it's conservative or whether they think that, you know, you're going to need surgery. And then of course, what would happen with the surgery after the surgery. So, and then of course, taking a look at what type of reviews that the physicians are getting as well. Definitely, you know, when you're having spine surgery or having spine issues is something that you really want to make sure that you're choosing the right physician. Okay.
Okay. You elaborated on bone versus nerve, and I haven't heard that before, and I appreciate that point. Mm-hmm. There's a neurosurgeon out here where I live who is renowned, and I went and saw him this past year, and it was a non-starter for him because of the blood issue. So, and I think, Alex, you may remember I emailed you a while back about surgeons for spine, and you gave me a list, and I've lost that list, but I was going to send you another email on that.
Yes, please reach out to me again, and I'll definitely help you, and I'll handhold it this time all the way through, so you make sure you get seen. Okay.
Okay.
Thank you. All
Thanks,
right, another
folks.
Rick Bruns.
There we go. I don't know if you remember me, Alex. I met you through Randy. Yeah, a number of years ago. I'm a frequent flyer of USC, you know, sadly. Dr. Selby did my insulinoma years ago to start off. And where that came from is that when it was diagnosed in one facility, they wanted to give me a weight loss surgeon. And then I went to Fresno, which is nearest to us, about 30 minutes away. And I found the best pancreatic surgeon. And he said, I won't necessarily agree to do it with all the problems you have. And he ended up by saying, we just have to find out what kind of witness you are. So that's the very next weekend we had a convention through the HLC, got me in touch with Randy, and then Dr. Selby did the surgery. And he took so good a care of me. And so I appreciate that. And so if you do see Randy, on behalf of my wife and I, Mary and I, please say hi. We usually stop by, but I haven't gotten to see him. We were there 2 weeks ago, and we're coming again next week to Verdugo Hills. Because now I can speak a little bit to that spinal surgery. I've had 2 surgeries on my neck. I need a 3rd revisitation on the neck. And I've had 2 surgeries on the back. I've got low artificial disc in the low back, but a plate broke. Dr. Spoonamore did the revisitation in the neck, and the 2 screws broke. So I'm doing a swallow test at Verdugo Hills next week in preparation of a consultation for a 3rd surgery. But lastly, in connection to that spinal surgery, I was 2 days from surgery with this revisitation of the back with Dr. Spoonamore, and insurance pulled it. And because it was Anthem Blue Cross, they said we had to go to a Blue Distinction Center. So I see you nodding your head, Cecilia. But that got me familiar with going with a neurosurgeon, and it was a good outcome. I had to go to another facility. It doesn't diminish you guys on my side. I always come to you guys. But yeah, just to educate others that a lot of it can be insurance that will dictate a certain amount too. So be ready for that, and then do the homework of finding good doctors. I found a good neurosurgeon at UCLA that was qualified to do that. So, but thank you again, Alex, for all that you're doing, and maybe I'll stop by and see you. You still on the 5th floor up there?
Yeah, we're on the 4th floor, actually. Yeah.
Fourth floor. Okay.
Yeah, but thank you.
You take care.
Thank you. You're going to be the bionic man by the time we see you.
Oh, yeah. Well, and I've had Omi did my rotator cuff surgeries. what is it? Neck.
Should be our poster child.
I know. Have a room with a plaque with my name on it.
Yeah, well, listen, Dr. Spudamore is excellent. So if you are having access issues,
Yes.
please contact me. So
It didn't fuse again. On the revisitation, it didn't fuse very well again. I had an initial one 25 years ago and they didn't put a plate in. He put the plate in, but then the screws cracked and now they're broke. And I've got fresh MRIs to show that there's separation.
Yeah.
I'm having swallow problems and other problems.
yeah, I'm sorry.
So,
I'm sorry
you
to hear
know,
that. But please contact me if I can be of help with that.
oh, thank you. Thank you, Alex. Well, you take care. Be safe.
Okay, I know we're kind of over time. Cecilia, do you mind taking up another question or two?
Not at all.
Okay, so we have Charlene Moody, who actually used to work at USC. Hi, Charlene.
I wanted to ask my blood card that I carry in my wallet. Randy helped me fill that out a few years ago. Should that card be changed or does it stay the same as it is now? I've had it 2 or 3 years, I'd say.
Sure, your advanced directive. So you really don't need to change it unless an agent has changed on there.
Well,
one
like
of the
you say,
representatives.
this the albumin has 1% blood in it, and the new medicine, I forget how you pronounce it, RADICIT.
Retocrit.
Should I write that in on the card?
You don't have to necessarily, because Retocrit, you can say you'd rather have Retocrit on there. And with albumin, remember, whether it's 5% or 25%, albumin is albumin is albumin. So really it's a matter of, do I accept albumin or not? Because
I believe it
always
was
gonna be a protein.
1% when a fraction is when Randy and I fill the card out, I believe.
Right. So you can update your card whenever you like. It's not something you have to do, but as long as you know what those are and you talk to your agents about what those are, you bring them up to date. That way, if you can't speak for yourself and you have the card, your agents will always speak for on your behalf, and they'll know what your wishes are in regards to those type of products.
I wanted to ask, does Verdugo have, I'm connected with Methodist, with a cardiology there, because I've had 3 heart surgeries, and they've all been done, no blood. Does Verdugo have a cardiology section the way Methodist does?
So you want to answer that?
Are you talking about that in terms of the same physicians, or are you talking about because maybe you've had open heart surgery, or what?
Yeah, I've had it started out, the aorta valve was involved. Then that went bad after 20 years and they had to replace it with a titanium. Dr. Matthews at USC did that. And now I have the microclip valve.
Okay. Yeah. So what we do for that is we refer you then to Keck. So that way they can do the surgery. Dr. Ray Matthews and Dr. Von Starnes and so forth. Excellent surgeons. I had aortic valve replacement because I was born with a valve defect, and I saw Dr. Von Starnes. Excellent. So best thing that I ever did for my health. So
he and Dr. Matthews did my second. Now, Dr. Lynn, are you familiar with Frank Lynn?
I am not.
He's at the Covina Hospital on 3rd there.
Yeah.
He did my microclip.
Yeah. Okay. Yeah. So that we usually would refer down to Keck. So they for us, it's a higher level of care, and you can't beat the physicians down at Keck Hospital.
Yes.
Yeah. Thank you, Charlene. If you have any other questions, feel free to call me, okay?
I'm sorry. What did you say, Alex?
Feel free to call me with any other questions, and I'll be happy to help you navigate.
I just like to say one thing for Alex. When I had the first heart surgery, I was in bad shape after the surgery. And Alex was a true brother and a friend to me while I was there. Because I mean, I went into arrhythmia, extreme arrhythmia after the surgery. And Alex was always there for me, and I've never forgot that.
Oh, Charlene, thank you. My pleasure. My pleasure.
When your heart goes into extreme arrhythmia, that's a very scary thing. And I've had it happen to me several times after that surgery.
All right. Well, we hope you're staying healthy, and we want to keep you away from the hospital if possible. So, but you know where to find us if you need to. All right. Thank you. Thank you, Charlene, and thank you for joining us. And I got one more person. Brian, you've been waiting patiently. If you want to ask your question.
Yeah, just briefly, about how big is your facility there?
Verdugo Hills Hospital or Keck?
Verdugo Hills Hospital?
Oh, we're 158 beds. So let's see, where do you live?
I'm in Washington State.
Oh, in Washington. Okay. All right. So, you know, I was going to try to give you some context, maybe in terms of where you are living in some of the community hospitals. I don't know I'm not familiar with many of them up in Washington, but it's 158 beds, but because we have both academic medicine and also community medicine, it's a pretty robust hospital as far as what types of surgeries that we do, what types of physical therapy we offer, our diagnostic testing and so forth. When you have a hospital like Keck, and they want their physicians to go out into the community and provide some of those same services that you can get at an academic medical center. When you have them going out to a community hospital like Verdugo, you can be sure that there's going to be some diagnostics, some surgeries, some therapies and so forth that you can't get outside of an academic medical center. So, and that's what Keck has been trying to do. We're even going to have an infusion center. We're planning on that at the moment, but it's just, even though it's a 158 bed hospital and some of the other community hospitals around us are maybe 300 and up, so almost twice the size, it's pretty powerful and the quality of care that you're going to get at Verdugo.
Yeah, I'm from Long Beach, California, so I used to have seen it before, but it was like in the late 90s, so it's probably expanded a bit from then.
It's changed since then, yeah.
Thank you.
Very good. Thank you, Brian, for your question. Cecilia, thank you so much. Thank you all for attending. You let the cat out of the bag about Methodist Hospital, so hopefully that'll be part of our USC family in the future, which will expand our footprint in regards to our community. But thank you all again. Please reach out to us if we could be of any service or if you have any questions that we can help with. We're very proud of Verdugo Hills USC Verdugo Hills Hospital and our entire USC family. And really, you are all the ones that make us successful too, because you take advantage of our services. So thank you. So please keep your eye out for any future events. We'll definitely communicate with you by email. They may continue to be virtual events like this, at least for some time. This is pretty convenient because we had people here from Washington, like Brian, from Hawaii, from Las Vegas, from all over the place. So I know this was a great educational event, and we know that you really appreciate and take advantage of it. So thank you again. Thank you again, Cecilia. Thank you again, Deborah. And thank you all. Thank you, Dr. Taneja. I know she's already gone. But thank you all, and we appreciate you for being with us.
Thank you very much.
Thank you.
Alex.
Thank you,
Have a good day.
Thank you.
Thank you.
Bye.
Bye.
Have a good rest of the day. Thank you.
Thank you.
Thank you.
Thank you.
Bye.
Aloha.
Bye.
Take care.
Aloha.